esteemed guests, and fellow oncology professionals. Welcome to the grand final of the second Global OncoConnect Symposium. I'm Dr. Nigar, your host for this closing session of our extraordinary 5-day event. As we near the end of the remarkable symposium, I want to take a moment to express our heartfelt gratitude to each and every one of you for your active participation and engagement throughout this journey. This symposium has been an incredible gathering of minds from around the world in a platform with over 30,000 oncologists coming together to share their knowledge, insights, and expertise with us. It's a testament to the power of collaboration and our collective dedication to advancing cancer care globally. The OncoConnect Forum within MedSynapse has been the heart of these discussions, where oncologists like yourselves have come together to exchange their ideas, tackle the challenges, and find solutions. MedSynapse has always been committed to supporting second opinions in oncology patient cases, recognizing the critical importance of these decisions. We provide a platform where experts collaborate to ensure the best possible outcome for patients. It's this commitment to excellence that sets us apart. Coming back to our symposium, today we have the privilege of hearing from our esteemed guest, Dr. Jinan Abdullah, a renowned medical oncologist from Kuwait. Her expertise is particularly focused on the Lung and Sarcoma unit in Kuwait, and she has notable publications in the field, including the role of Notch in GI tumors. Now, without further ado, let's turn our attention to Dr. Jinan Abdullah as she shares her insights on the interesting topic of potential pathways forward for targeting Kristen rat sarcoma virus mutations in non-small cell lung cancer. Her wealth of knowledge and experience promises to be a fitting grand final to our symposium. Welcome, Doctor.
Thank you, Dr. Nigar, for the introduction. So, as she said, I'm going to be talking about KRAS mutations in non-small cell lung cancer. Now, one thing that you do need to understand about KRAS mutations is that it is very different in biology from the other mutations found in non-small cell lung cancer. And because the biology is very different, once you understand the biology, you will understand how the clinical trials are different. You will understand why there is resistance to this drug, the efficacy of this drug, and how we can overcome resistance. So I'm going to spare some time initially explaining to you the difference in the biology of this receptor. And once you remember that, once you understand it, it will be very easy to understand the clinical parts. So at the moment, as oncologists, when we have a patient with lung cancer, we already know as a standard practice that we need to look for the mutations, the EGFR, the ALK, the ROS1, the BRAF mutation. Now, there are other emerging mutations that are done in some hospitals, depending on the availability of the drugs, the availability of the tests. But there is one drug, the KRAS drug, that we knew in the past that it is there, it exists, it can cause cellular growth in lung cancer. We just did not have any drug for it, and therefore we never actually tested for it. Now, KRAS is very different than other mutations because it is not a tyrosine kinase, it is not a gene fusion protein, it is actually a GTPase. So it behaves very differently than the EGFR, the ALK, the ROS1, etc. Now, the reason why it was very difficult for us to synthesize a drug against the KRAS is because the protein itself has a very smooth surface. It doesn't have this very specific topography where we can synthesize a drug that can sit on the receptor and block it. And therefore, for a very long time, we actually didn't know how to synthesize a drug because the drug will just slide and fall off. So we had to do very specific studies called the crystallographic studies that allowed us to look a little closer into the molecular structure of this protein and allowed us to identify a region called the switch II region that allowed us to synthesize a drug that can sit in that region and block it. So if you look at the protein here, imagine that this is the KRAS protein. There is a region right there called the switch II pocket region where we can synthesize a drug that can go sit down there and block it. Now, this region has another part to it called the Y96. They both interact together. And there is another region that is found only when KRAS is mutant. The difference between a KRAS mutant and a KRAS wild is basically one single mutation. And this mutation is a point mutation in codon 12, which codes from glycine being switched to cysteine. So in the wild form, it is glycine. In the mutant form, it is cysteine. So you have the cysteine 12 region, you have the Y96 region, and then you have the switch II region, which they could identify with crystallographic studies to design a drug to block it. Now, as I said, it is a GTPase protein, not like the others, which means it behaves differently. If you have a cell here, this is the cell membrane, okay, and you have the GTPase protein. It is a membrane band embedded protein, so it is sitting right here. Now, this protein, when activated by growth factors, it will phosphorylate GDP into GTP. GTP is the active form. GDP is the inactive form. Once it gets activated by the growth factors, it will lead to intrasignaling pathway with MEK, ERK, PI3 kinase mTOR, and the MAP kinase. All these different pathways will go into the cell's DNA and allow for growth and proliferation. What happens with these drugs is that when they bind to the switch II region, they will keep it in the inactive form where GDP accumulates. The GDP will bind to the KRAS and block this region. When it is mutant, the GTP accumulates. The GTP has a very high affinity for the KRAS protein. It will keep binding the KRAS protein and will lead to irregular signaling for the cells to uncontrollably grow and divide. Now, the KRAS protein has a very high affinity for the GTP. So if you have a very high concentration of GTP inside the cell, it's very hard to block the KRAS mutation. And this was another reason why for many years we did not know how to block it. There's a lot of GTP, because I've only drawn one molecule here, but imagine so many GTP molecules binding to all the KRAS mutations, leading to an irregular activation of the protein. So the drugs that bind to the switch II protein keep it in the GDP inactive form. The GDP becomes more dense inside the cell than the GTP, binds to the KRAS protein and leads to inactivation and stops the cell growth. Now, once you understand this, you will understand the resistance to the drug and where we are going with the KRAS mutations. The first thing is that the regulator for the KRAS protein, one of them is called the SOS1, which stands for son of sevenless. I'm not sure why they called it this way, but this is a regulator of the KRAS protein that helps in the regulation of it. We said that there's the MEK, ERK, PI3 kinase, mTOR, and MAP kinase, all involved in the intracellular parts. And then the other thing is that KRAS is a very general term. In fact, KRAS are many different proteins. There is KRAS G12C, which is the most common, accounting for around 40 to 50% of all KRAS mutations in lung cancer. But there are many others. There's G12V, G12D, there are so many other different types that I will show you later on in the slides. So if you imagine, we only studied the most common form of KRAS, which is the G12C. We did not study or manage to create inhibitors that block the other types of KRAS. So if you think about it, there are other KRAS proteins inside the cell that we are not inhibiting. This can also lead to the activation of this pathway. Why is this important, and why am I spending so much time explaining this? Because now we have two drugs that have been synthesized against the G12C by binding to the switch II protein. We have the sotorasib, which was validated by the EMA and the FDA as a second-line treatment for G12C mutant patients, which will lead to an increase in the PFS, and it was validated by a trial called CodeBreak. And I will explain to you the CodeBreak later. And we have a second drug, adagrasib, which had an accelerated approval by the FDA with a trial called the Crystal trial. And the Crystal trial is only a phase 1 and phase 2. The phase 3 is pending. Now, if we ever have resistance to these drugs, if any patient does not respond to these drugs, these serve as potential future targets for treatment. So instead of just inhibiting the switch II region, we can try to inhibit the Y96 region. We might try to inhibit the G12C region plus other targets in the mTORPI3/MEK/ERK pathway. Or we can try to inhibit other types of KRAS, a pan-KRAS inhibitor that will stop other signaling pathways from coming. And as I will explain to you later, when we start using these drugs, we have a primary resistance and we have a secondary resistance. Primary resistance is when the actual drug is not working enough due to, let's say, the Y96 or other KRAS mutations working, or because the patient has other mutations. I will talk to you about other mutations that can exist within the patient, like the KEAP1 and the STK11. These are mutations that can exist within the cell that can lead to resistance to these drugs. But it can also be an acquired resistance where we use these drugs. It initially starts to work, but then the cell itself starts to mutate in either of these regions, and these regions, and other KRASs, leading to resistance to the drug. So as I said, the KRAS mutation is a GTPase, and the GTP form, it is the active form. It can lead to intrasignaling pathway leading to cellular growth by the MEK/ERK, PI3, and the MAP kinase. It has a cysteine 12 codon, the codon 12 region. It has a Y96 region. At the moment, we only have two drugs that only target the G12C region. Now, all of this information, I'm going to explain to you how it works within the clinical trials with my laptop. Okay, so now I will just show you the molecular structure of the KRAS protein that I already explained to you on the whiteboard. And then I will explain to you a bit about the epidemiology, and then we'll go through two clinical trials, mainly the CodeBreak, that allowed for the validation of anti-G12C KRAS inhibitors, and the Crystal trial. Then I'll just explain to you a bit about special circumstances like the brain metastases and for patients who have resistance to these medications. So first of all, the biology. So I explained to you a little bit about it. If you look here, you'll find that there is a KRAS protein, mainly the G12C is the most common one that we have studied. And using specific studies, we have been able to identify the switch II region, which is depicted here in green. And the switch II region is bound to a Y96, an H95, and a Q99 region, all which may serve in the future as potential targets for inhibitors. You can see here the cysteine 12 region, which is present in the mutant form of the KRAS. And as I told you, in the normal form, upon the binding of growth factors to the KRAS protein, there is a signaling pathway of the MEK, ERK, PI3 kinase, and the mTOR leading to cellular proliferation. But then when you have a mutation, specifically the G12C, where you have a codon being switched from glycine to cysteine, then the KRAS is always in the GTP active form, leading to irregular signaling and cellular growth and proliferation. Now, I have just left this slide because a lot of people do wonder what is the best way to test for these mutations. Some people like to use immunohistochemistry, some people use PCR, etc. Now, for the KRAS, it is actually better to use the NGS for several reasons. First of all, the NGS is the best way to detect the KRAS mutation. But not only that, as I will explain to you later, the KRAS mutation may exist with other co-mutations, and these co-mutations can lead to a difference in the efficacy and the survival of these patients and how these drugs are effective on these patients. And therefore, it is better to look at the entire landscape because, as I explained to you, if you have a cell with only KRAS G12C mutation and you are inhibiting it with a KRAS inhibitor, it is not the same as if you have a cell with several KRAS, different isoforms of KRAS, G12V, G12D, other forms that are not inhibited, or if you have other co-mutations like KEAP1 or STK11 or other mutations that may lead to a poor prognosis. So it will actually give you a much better understanding of the patient in front of you than if you just look for one mutation. So an NGS does actually help much better. Now, I explained to you a bit about the epidemiology. The KRAS overall, there are many different isoforms of KRAS. Altogether, there are about 25 to 30% of non-small cell lung cancer, but the G12C alone will account to 40% to 50% of these KRAS forms. If you look at all the non-small cell lung cancer together, the KRAS G12C is around only 13%. But it is making up 40 to 50% of all the different isoforms of KRAS. And again, this is another reason why it is good to do an NGS. You will get to know all the different KRASs that you might not be inhibiting with the validated drugs at the moment. So here we come to the different trials that I wanted to explain to you. I told you that there are two trials, the CodeBreak and the adagrasib. Now, the CodeBreak is what I'm going to explain to you first of all, because it's what led to the validation of sotorasib in most countries. I will not just explain to you the randomized control trial, but I will explain to you the phase 1 and phase 2. How did it come to become a phase 3 trial? So the CodeBreak 100 is the phase 1 trial. It was a classical escalating dosage trial where we were looking at the tolerance of the drug, the safety of the drug, where we took patients from different types of tumors, not only non-small cell lung cancer, but for example, also colon was involved. But they must had a G12C mutation, a KRAS G12C mutation, and they must have had progressed on other lines of treatment in the past. So patients who have already progressed on other lines of treatment, who had a G12C mutation on any solid tumor, and they must have had no active brain metastases. Now, this does not mean no brain metastases. This only means no active brain metastases. So if they're stable or treated, then they were included. Now, the primary endpoint, of course, this is a phase 1, so it was only the safety, and there was an escalating dose from 180 progressively up to 960 milligrams orally. Now, the efficacy of this CodeBreak 100, as you can see, was a median PFS of about 6.3 months. Now, this was a trial that was done mainly in the USA, so it was more of a homogeneous group of patients. There was no control arm, so it was only monotherapy. Will they respond to sotorasib with a good tolerance or not. This then led to the phase 2 trial, where the patients were mainly non-small cell lung cancer patients with no active brain metastases, so either stable metastases, treated, or no brain metastases. And they were given the best tolerated dosage, which was the 960 milligrams orally daily until progression. Now, these patients did have non-small cell lung cancer with a G12C mutation that have already progressed on other lines of treatments, mainly platinum and immunotherapy. The primary endpoint was the overall response rates. And again, you can see about the same, a median PFS of 6.8 months. This then led to the CodeBreak 200 trial, which was a classical randomized controlled trial with a 1-to-1 randomization between sotorasib 960 milligrams daily, or in the control arm, what we would normally give to patients who have progressed on platinum and immunotherapy, which is, of course, docetaxel, 75 milligrams per meter squared 3 weekly. So it was a 1-to-1 randomization of around 171 to 174 in each arm. Now, this was a classical randomized controlled trial in more countries, not just the USA. So there was a bigger proportion of patients who were Asian. So the PFS here was slightly lower, maybe because they were more heterogeneous patients, of 5.6 months in the sotorasib arm versus 4.5 months in the docetaxel arm, but it was significant with a p-value of 0.002 and a hazard ratio of 0.66. Now, the overall survival was not met, but the design of the study was not to detect any changes in the overall survival. The overall survival in the sotorasib was 10.6 versus 11.3 in the docetaxel, with a p-value of 0.5 and a hazard ratio of 1.01. Now, it could be because the study was not designed to check for any overall survival benefits, but it could also be because there was a large proportion of patients who did cross over from the docetaxel arm to the sotorasib arm, around 34%. That's a big number. Either way, it did not show any benefits. Now, regarding the safety of this trial, I did not show this slides for the phase 1 and phase 2. Most of the side effects were GIT upset and increased ALT and AST. If you look at the slide here, the gray regions are for the docetaxel and the blue regions are for the sotorasib. You can see that for most other side effects, alopecia, fatigue, appetites, neutropenia, febrile neutropenia, it was mainly for the docetaxel and not much for the sotorasib. But when it comes to diarrhea and increased ALT and AST, it was more significant in the sotorasib arm. Now, this is very different in this trial. What we did is they also asked patients, do you feel better or not? Do you have more pain? Do you feel more tired? Do you feel more comfortable on the sotorasib or not? And the patients themselves were to tell how they feel about the drug. Do they feel like they can tolerate it or not? So this is the sotorasib versus the docetaxel. The regions in blue and turquoise are regions in which the patient was doing quite well. And then you have the yellow regions in which the patient is starting to get annoyed. The orange regions in which they're really annoyed, and red is when they are pretty much unable to tolerate it. And if you can see that the patient self-assessment shows that more patients were able to tolerate the sotorasib better. So what this basically means is that the sotorasib will increase the progression-free survival and the quality of life of patients, but probably not the overall survival for the time being, according to this trial. So this is for the sotorasib. Basically, we can give it to patients who have a KRAS G12C mutation, not another mutation, who have already progressed on immunotherapy and platinum therapy, it will increase the PFS to around 5.6 months with a better quality of life. One thing that I forgot to mention to you is that a lot of these slides are taken from a lecture by Dr. Sanjay Popat in the ESMO website, which was talking mainly about oncogene-addicted non-small cell lung cancer. It was held in Barcelona. And some of these slides were again taken from either the European Lung Cancer Congress held in Copenhagen or the World Cancer Lung Conference held in Singapore. So this was a slide taken by Waterhouse, and then it was adopted by Dr. Sanjay Popat in his lectures. I have left the references at the end of the lecture. The second trial is the Crystal trial. The Crystal trial, I'm going to show you the phase 1 and the phase 2 trial. The phase 3 is still ongoing. So the Crystal trial is a very, very similar in design for a drug that is again designed only against the G12C mutation in lung cancer. So the beginning phase 1 trial is a very similar design to the CodeBreak phase 1 trial, where they took patients with different cancers who have already progressed on previous lines of therapy, not necessarily for lung cancer, who had no active brain metastases, and then there was an escalating dosage of adagrasib to check for the best tolerated dose. And the best tolerated dose was the 600 milligrams BD with an objective response rate of around 43%. And you can see here in the trial that a lot of patients did actually have a decrease in the tumor burden over time. Very similar to sotorasib, you can see that most of the side effects were GIT upset, increased in L8, in ALT and AST. And this then led to the phase 2 trial, very similar to the CodeBreak, where there were only non-small cell lung cancers with KRAS G12C mutations who have progressed on other lines of treatments, who had a stable or inactive CNS mutations or no CNS lesions. The overall response rate was the primary endpoint. And you can see again, it was around 6.5 months as a median PFS, with a median overall survival of 12.6. Now, the phase 3 trial, similar to the CodeBreak, is still ongoing. We might see it very soon in the upcoming congresses. It is the adagrasib 600 BD versus docetaxel in KRAS G12 mutant non-small cell lung cancer patients with stable, inactive, or no brain metastases. The only difference is that the randomization is 2-to-1. So it is still ongoing. We will see the results of this trial. Now, when we talk about the brain metastases, sotorasib, adagrasib, how do they react to the brain metastases? So there were sub-analysis done in the CodeBreak trial in patients with or without brain metastases. Now, the method used to assess for brain metastases was the RANO method, which is a bit more complex. You can see that there is a bit of a difference between patients who were on sotorasib versus no sotorasib. But again, patients without brain metastases had a much better prognosis than those without any brain metastases. So there might be some penetrance, but not a lot. Now with the adagrasib, this is just another graph showing the overall survival of sotorasib versus docetaxel in the CodeBreak 200 in patients who had a CNS lesions, again using the RANO methods. You can see that there is a difference between using sotorasib versus docetaxel in patients who have a CNS metastases. You can see that there is some benefit of sotorasib. The red line is for the docetaxel and the blue line is for sotorasib. You can see that there is a bit of a difference. For the adagrasib, very similarly, you can see that there is some effect on the CNS metastases, with one patient having a complete response, overall response of 5 in 5 patients. Yes, exactly. So the adagrasib probably does penetrate the CNS, maybe a little bit more. There were some preclinical trials in mice where there was imaging to show where the drug is going that did show that the drug does penetrate the CNS. I did not include this slide. But yes, it does have some effects, probably more. We're not sure yet. We need to wait for the final results. Now, what about the resistance? Now, if you remember what I explained to you initially in the board, I explained to you that there are other mutations that can exist within the cell, either within the intra-signaling pathway, whether with other mutations like KEAP1, STK11, or of course other KRAS mutations that can lead to irregular cellular proliferation and growth. So this is a graph that is showing patients who were on sotorasib, who progressed either 3 months or less after being on sotorasib, or patients who progressed after or equal to 6 months after being on sotorasib. And it seems to us that patients who have a KRAS G12 mutation plus other mutations like KEAP1, STK11, STKN2A, or SMARCA4 seem to just simply do worse than patients who only have a KRAS G12C mutations. You can see that all the early progressors of 3 months or less did have a co-mutation with the KRAS G12 mutation. And now one explanation is that here, patients who have an STK11 mutation seem to have a cold microenvironment, meaning they have an environment, a cellular tumoral microenvironment that simply has less immunogenic cells. If you look here at the cells, at the graphs, they are looking at the number of CD4 and CD8 cells in patients who only have a KRAS mutation, depicted here with the letter K and a white bar, versus KRAS mutation and an STK11 mutation, depicted here with KL in black, in a black bar. And you can see that there are less CD4, less CD8 cells, which means that probably there are just less immunogenic cells, which means that the tumor itself has a microenvironment that leads to a poorer prognosis. This is again some graphs showing the differences in the overall survival of patients who have only KRAS mutation and no other co-mutation, depicted here in a blue line, versus a co-mutation with either SMARCA4, CDKN2A, or KEAP1. And you can see that those who have a coexisting mutation always have a poorer outcome. And this is another reason why it is better to do an NGS where you can see all the mutations, and then you can kind of tell what the specific patient in front of you will behave like after you prescribe to them the inhibitors. Are they poor responders? Are they better responders? Are you expecting to have to get more aggressive with the treatment? Are you expecting a poorer prognosis? It will just give you more information. And again, here, this is taken from the CodeBreak 200 randomized control trial, where again, it is classifying patients into either early progressors in red or late-term progressors in blue. And you can see that patients who had a mutation just simply were progressing earlier than patients who did not have any mutations. You can see here patients with a mutation or whether they were wild regarding KEAP1, STK11, etc. And you can see that patients who had a KEAP1 mutation somehow just do not do very well. Now, we spoke about the mutations in the beginning. Patients who, now you're going to start them on the sotorasib. You did the NGS, you found the KRAS G12C mutation. You saw that it was there. You started them on sotorasib. Some of them were early progressors because they have a pre-existing co-mutation. Now, there are other patients who will not have another coexisting mutation, who you will start on sotorasib or adagrasib, but then you'll realize that they will start to progress on time. And what they did is that, in studies, is that after the patient started to progress, they did another biopsy, whether liquid or tissue, and they realized that there are other mechanisms of acquired resistance of patients who started to have other coexisting mutations, who were not there in the beginning, who developed actually, it's not coexistent, it's de novo mutations, new mutations while they were on the drug. So this is a slide taken from Awad, which was published in the New England Journal of Medicine. So these were patients who were on KRAS G12C inhibitors, who in the beginning did not have pre-existing co-mutations, but started to have other KRAS mutations with time. And you can see here, remember when I explained to you on the whiteboard that we're inhibiting the KRAS G12C, but there are other KRAS mutations in the cell that are leading to the intracellular growth pathway. So here you can see patients with G12C acquiring new mutations with the G12D, the G12R, G12V, G61H, etc. They are acquiring new KRAS mutations while being on the drug, which led to resistance to the drug later on. Now, some of them acquired mutations in other pathways, like the MAPK, the PI3 kinase. This was the intracellular pathway, so we're not looking at the cell membrane anymore. We're looking at the intracellular pathway. BRAF mutation, NRAS mutation, RET, etc. So these are other mutations, and of course, some of them even acquired resistance with a gene fusion protein. So upon progression, new biopsies were taken, either a tissue biopsy or a liquid biopsy showing new mutations. Now, with a tissue biopsy, not only is it molecular mutations, but some of the patients, the cancer transformed from being an adenocarcinoma to being a squamous cell carcinoma, which means that the entire tumor starts to behave differently. This is again showing you some of the different acquired mutations, but from a different journal in the Nature by Zhao. And now we're talking about, now you have a resistance to these mutations. How would you respond to them? Well, if you remember what I explained to you initially in the whiteboard, I drew for you the cell, and I showed you how you have the KRAS G12C mutation, which is a protein that has the codon 12 cysteine region, but it has also another region called the Y96 region that can lead to newer drugs being synthesized in the future that can block it. So we're not only blocking the switch to region with the adagrasib and the sotorasib, but we're also blocking the other regions. But then, if you remember the cell, the diagram that I explained to you, there are different KRASs. So we can block other KRAS mutations or design drugs that can block all KRASs, pan-KRAS inhibitors, not just the G12C. And of course, we can inhibit the intracellular pathway like the PI3 kinase, the mTOR, the MEK, ERK, etc. And there is a study at the moment being run in Harvard where upon progression they take the plasmic DNA and they try to check for any molecular mutations and try to understand more about the mechanisms of inhibition. So basically that summarizes the KRAS mutation. As I explained to you, it is different than other mutations in lung cancer. It is not a tyrosine kinase. It is not a G fusion protein. It is a GTPase protein, where the GTP is in the inactive form, the GTP is in the active form. It binds to the KRAS, leading to intra-signaling pathway with the MEK, ERK, PI3 kinase, and the MAP kinase, leading to cellular growth and proliferation. The KRAS G12C can become mutant with a point somatic mutation, coding glycine being changed into cysteine on codon 12. So you have the protein. We are blocking it with two different drugs at the moment. We have sotorasib and adagrasib. Sotorasib is validated by the EMA and FDA, increasing the PFS to 6.8 with side effects mainly in the GIT system, and adagrasib only being validated by the FDA at the moment. The phase 3 trial is ongoing. These drugs bind to the switch to a protein, blocking the KRAS mutant form and the inactive form. In the future, we might be able to bind and block the KRAS protein either in the other regions like the Y96 we can probably design drugs that can bind to all the KRAS proteins, or we can target the intracellular signaling pathway. So we have the CodeBreak trial, we have the Crystal trial. The CodeBreak trial showed only a significance in the PFS. The Crystal trial is ongoing at the moment. And if you have a coexisting mutation, like the KEAP1, the STK11, then you probably have a patient with a poorer prognosis.
Dr. Jinan, we're truly grateful for your outstanding presentation on potential pathways forward for targeting KRAS mutations and NSCLC. Your insights have been very valuable, shedding light on the critical areas of research and treatment. Thank you so much once again for participating and for collaborating in our second Global OncoConnect Symposium. Before this wonderful event comes to an end, I would like to extend our heartfelt appreciation once again to our audience for their active participation and engagement throughout this 5-day global event. Your enthusiasm and commitment to the field of oncology is truly inspiring. And now, as we conclude this symposium, let us remember that the journey doesn't end here. Stay tuned for more exciting events ahead as we continue to explore new horizons in the world of oncology. If you wish to collaborate or have any inquiries, you can always reach us out. Let's continue working together to advance cancer care for the betterment of patients worldwide. Thank you.